everyone. I'm Carolina.
And I'm Rebecca.
And welcome to the podcast. And then they wondered, where we will be talking about things that we wonder about, maybe you wonder about, and things that everyone maybe should wonder about.
Exactly. And in this season of the podcast, we're talking about hospice care, end of life, having some really, really great conversations around a topic that a lot of people don't talk about until it's too late.
Right.
And then they wonder, what does it mean to live and to
I'm Rebecca.
I'm Carolina.
And we're continuing our conversation today about hospice care, end of life versus palliative care. Today, we really want to focus on some specific disease processes and talking about when to know it's time to have this conversation. It's time to really be looking at who you would want your provider to be and some things like that.
Yes. So technically speaking, hospice means your physician believes that if the disease continues its course without intervention, without treatment, you could pass in 6 months or less, technically speaking. However, the expectation and sort of like the knowledge is that's not the word I'm looking for.
The understanding, or like we know in healthcare, that once we get involved, that changes the timeline.
It's my second brain here. Or the other half. Yes. So once we get involved, we do change that timeline. And I think that physicians are well aware of that. And so are the, people behind the scenes that are paying for hospice.
The Medicare behind the curtain.
Yes. So there is that understanding that probably you will outlive that prognosis once hospice comes on. In fact, we do have people that graduate off hospice care because they are thriving.
We take them from failing to thrive to thriving.
Yeah. But that's a conversation for another day.
We'll put that in a different podcast.
Yeah.
We'll save it.
Ooh, too many things. Anyway, so what hospice means, talked about that, but with specific disease processes. So, with like dementia or COPD or congestive heart failure, end stage renal disease, several comorbidities. I think hospice is mostly known for cancer. Or that was sort of like the beginning.
Where it got started. That was like the beginning of it all. And originally, so many people think that hospice care really is for that last 3 days of their loved one's life.
Yeah.
And that is originally what it was. But the Medicare benefit has been expanded to include so much more than just the last 3-4 days of someone's life. And I think that's one of the biggest misconceptions. So let's take a look at, say, somebody with heart failure.
Okay.
What would it look like when we need to start having that conversation?
So somebody with heart failure, a lot of times, we tend to look at numbers. So if you have congestive heart failure, the numbers that they're looking for are ejection fraction.
Okay.
An ejection fraction, what that means, for you, our audience, is how much blood, oxygenated blood, your left ventricle is pumping out to the rest of your body. Normal is 55 to 65%, about. With congestive heart failure, if that number is 15% or lower, that will qualify you for hospice pretty much automatically. Now, here's the thing. You get the right treatments for congestive heart failure, that number can actually go up. And nobody's checking it after you're on hospice.
So okay. So let's pretend for just a second. My grandma, she got diagnosed with heart failure 4 years ago.
Okay.
She's been on her medications, her blood pressure's been regulated, but recently she's had 3 falls. She's had to go to the hospital for 2 of them. She hit her head, she cut her head. She's also, when she stands up, she'll walk and then she just has her legs just give out.
Yeah.
And she didn't need oxygen 4 years ago, but now she's on 2 liters of oxygen at home. And especially when we go out, it takes her several days to she just sleeps a lot when we get back home.
Yeah.
So what about her? Obviously I don't understand all the stuff in her chart, but just that's what's happening let's say that's what's happening with my grandma. What would you tell me?
I would probably say, I would ask a lot more questions.
Yes. So
how much is she sleeping? Has that been a change in the last 6 months? How much is she eating? when did she start to need oxygen versus, things like that. When she goes to the hospital, they may be for falls, but in actuality, it's because of exacerbations, because congestive heart failure kind of messes with your brain, and you do become confused and you do experience more falls. So practicality, as far as that goes, that would be a good indicator. And I would be saying, I would start looking at hospice in that.
Start having that conversation.
In that situation, yeah. Especially if you kind of are seeing like, this isn't getting better. She's needing to go to the hospital more often. I don't want that for her. Because again, in our previous conversation, going to the hospital more is actually more detrimental to your health. So that would be kind of the questions that I would ask if you don't have that specific number. Like, okay, she's on oxygen now. Does she have chest pain? Is she able to move as well as she used to? Because that would be like her symptoms now are catching up to her.
And some of the things are really not necessarily heart related. Obviously the fall, it doesn't seem like that's related to your heart, or a lot of times a loss of appetite, loss of interest in food, restlessness at night, not being able to lay flat. That's a big one. People don't really think about necessarily always as being related, but that's one of the big questions I ask when I'm admitting, especially like a cardiac patient, is do they sleep flat in bed? And most of the time what I'll hear is if they qualify for hospice, oh no, 2 years ago they started sleeping in the recliner and they don't sleep anywhere else. They say they can't sleep anywhere else but in the recliner.
Yeah, that's a big
that's
marker.
kind of a big sign.
They're just not comfortable in bed, and so they've been sleeping in the recliner. Most of their existence is in the recliner, typically, is what you find too.
They kind of, that's their home, and that's where they live. Also confusion, forgetfulness, some of those mentation symptoms. Again, they're secondary to the CHF. They're kind of caused by that. So any cardiac illness, is that something to look at? All right, so let's move on to, like, say, a dementia patient. Again, my Grammy, she has dementia. My Grammy actually did pass away for dementia when I was very young. But so let's say we have a dementia patient, and that's what we're dealing with. What are some of the things? Because dementia can be, okay, there's a lot of different kinds of dementia, but it can be a long, kind of slow process that also kind of sneaks up on you.
Yeah, those neurological ones tend to be, for sure. But the overall dementia umbrella, I would say, are they walking anymore? Like, that's a big one. They're still walking, but they're falling all the time.
They're furniture surfing and they've had 7 falls in the last week. Like, that's not walking.
No. That's still attempting.
That's just falling.
Falling slowly. I would say, like, what's their eating like? A lot of times too with dementia, whenever it's more advanced, they start to like pocket that food.
So they look like they're eating, but then they have all this food in their mouth that kind of comes out over the rest of the day. You find it on their shirt. They have a hard time swallowing it, so there's a lot of coughing involved after they eat or drink anything. They start not wanting it, honestly. Like, the appetite just really plummets. And so, like, with those kind of scenarios, you really kind of are seeing like an overall decline in their walking, in their sleeping habits, in their talking habits, really, with dementia. Speech goes down a little bit too, where you're noticing they can consistently maybe say the same 5 to 7 words a day, or they're not talking at all, or you're having stretches of time where they're not talking at all, and then maybe one day they'll say a word. Those are really, that decline in language is a big indicator.
They are. So all of those things, walking, talking, eating, sleeping, incontinence, like, toileting, those are like your 5 solid markers to look at. So same again, and we can probably put them down in the comments below.
Yes, we should do that. We can add these down below so that you can really look and look at kind of the markers for each disease process to see where your loved one is, or if you're the patient, kind of when to start considering looking at hospice options.
Yes. So walking, talking, eating, sleeping, and toileting.
Yes.
I would say would be the 5 markers. Really, you can apply these to any disease process.
Honestly, yes, that is so true. When those things decline, and one thing that I see so often with all these disease processes is this pattern that leads up to the admission for hospice. And it's a pattern of, well, we were home, we went to the hospital for a declining status, whatever the disease process is, it got worse. We had a fall, whatever. And again, like Carolina said, that's a symptom of the disease process getting worse. It's not, the fall isn't usually the problem. It's usually that's just kind of the road sign saying there's a problem. So you go to the hospital, and then from the hospital, we go to rehab. We spend time in rehab. And then either we never make it out of rehab, we just go straight back to the hospital for another decline, or we come back home for 3 or 4 days and then go back to the hospital. And after doing that a few times, usually what happens is the patient starts to say, I don't want to keep going to the hospital.
Yep.
This is exhausting.
Mm-hmm.
And that's the point where we get called in. That being said, several of those visits can be avoided by knowing these things early.
Yeah,
You
it
can
almost
actually-
feels like at that point it's kind of late.
It's kind of late. That's an late admission. You know, if we've done this 3, 4 times before you get to us, that's a late admission.
Yeah.
And we could have avoided a lot of those back and forth to the hospital, kept your patient a lot more comfortable. And again, that goes to that quality and quantity of life. Every time we can avoid a hospitalization for the most part,
Mm-hmm.
we increase that quality and quantity of life, and that's our goal.
Right. Yeah. Especially, I'm sure you all would want to have your Grammy on for a little bit longer
Mhm,
too. You
for
know.
sure, for sure.
Instead of like, if we can, we had a president actually. I always give this example to people when we're kind of thinking about hospice and my informational visits. We had a patient on hospice or we didn't. I'm sorry. We did not have President Jimmy Carter on hospice
Wait,
services.
Are you a famous hospice nurse and you never told me?
No. No. President Jimmy Carter was on hospice services for 2 years.
Really?
Mhm.
I didn't even know that.
Yeah.
You are such a good, interesting fact person. I
I'm a
love that.
researcher, you
You're
know?
a researcher.
Yeah.
Oh, that's interesting.
Isn't that interesting?
Yeah. So
Yeah.
was he able to pass away at home
Mhm.
with? Wow.
Yeah, he was on hospice care for 2 years. He was
Wow.
actually, I think, admitted for dementia.
Really?
Yep. Mm-hmm. And was around for 2
Wow.
years. So.
Well, if a president can do it.
Right. You all can.
Exactly. All right, so this one is a little bit different. The other ones we've talked about, that decline that you as the family or caregiver or loved one is most likely going to see. But with cancer,
Yeah.
that's kind of a different conversation.
Mm-hmm.
So let's talk about cancer and how that looks different. And cancer is probably the disease process where when the final decline happens, that one is where the family feels the most blindsided consistently.
Yes. I think with all of these disease processes that you kind of don't just, nobody ever goes like, brr. It's never a straight line. It's always
Mhm.
kind of a little bit of a wave to the end.
Mm-hmm.
And we know what is normal and what is not, and
Mhm.
when to step in or intervene. That's why I think hospice is important,
Mm-hmm.
because you have those trained eyes that can really say, that's normal, don't freak out, it's okay, this is
Mhm.
all part of
This
it.
is just part of the process.
Yeah, or that's not normal, let me intervene here.
Let's test for a UTI or something like
Yeah,
that.
so
Mhm.
so that's super important for that reason. But with cancer, you know, the body hangs on for a really long time until it doesn't.
Exactly.
And then it's like a total decline.
That's the one that you can be here. I mean, you can be out golfing, and 4 days later, we're having that final conversation, starting the comfort meds,
Yeah.
things like that. Also, just with the way that cancer cells multiply, it's a little
Right.
bit different.
It
When you think
is.
about the duplication,
Mm-hmm.
that can, you can be, you're like you said, you're okay until that duplication overwhelms the body, and then it's just
And then, yeah.
very quickly. And so often with cancer patients, it is very, very hard to wrap your mind around what happened.
Mm-hmm.
And one of the big things I see with that at the end is just loved ones asking, did I do something wrong?
Mm-hmm.
Or just kind of being in shock of, this happened so fast. And so really for that, once aggressive treatment is stopped,
Mm-hmm.
it's really ideal, even if you feel like you don't need it yet, to go ahead and get a hospice consult, because getting to know your team early, letting them get to know you early, having that relationship is really helpful and important.
And it can really prepare you for
Mhm.
that massive decline.
Exactly.
Honestly, like, because it does come quick and it really does shock people. Like, well, they just had treatment like a week ago
Mhm.
and they felt better and they were doing fine, and then they're not, you know.
Mhm.
And so, but you know, your providers can prepare you for that, especially since you know, I always say hospice doesn't care for the patient, it cares for the whole family unit.
It really is all inclusive.
Yeah.
And one thing about hospice care that isn't probably talked about enough is just simply that we do continue to follow that family, your loved ones, anybody connected with that patient for a year afterwards to provide
Mhm.
continued support.
That's right. It's such a benefit. I mean, honestly, everybody just needs to go to hospice.
Can you sign me up?
No.
I
You don't qualify. Thank God.
Okay, so there's this other kind of group of patients that they don't have like just one thing. They have
Yes.
a lot of things going on. They have a lot of things happening, and just over the last several months, they're having more falls. They're having more confusion in the evening. They've lost weight. Maybe they've lost like 30 or 40 pounds in the last 6 months to a year, and they're going back and forth to the hospital more. They've had infections, they've had pneumonia, and they've had a UTI, and they've done the hospital, and they've done rehab, and it's not necessarily just as simple as there's one thing wrong. There's multiple
Right.
diagnoses, but there's this overall decline happening. Let's talk about that.
Yeah, it kind of looks a little bit like a failure to thrive in an adult, but you can't call it that. And they also have like a lot of other things going on. Like, sure, they could have COPD, they could have CHF, they could have dementia, but they're not end stage. But all together, no, of anything. But all together, the combination is, sometimes your body's just done.
Exactly.
And I always say, like, we exit this world just as unpredictably as we enter it. For any of you that have had babies, oh, you're dilated so much, your baby could come any minute now or any day now, and then doesn't, or comes quicker. I had 2 preemie babies actually, and they were like, yeah, so
wow.
4 weeks before they were due.
Oh wow.
I know. So nobody tells you.
Yeah.
Surprise, here it is. They think this is your due date, but in actuality, it's whenever baby's ready. And so I think too, for exiting the world, it's sort of similar. These signs could be present or not, and it still happens.
So this is going to sound really weird, and this might be a good pin to end this podcast on, because I'm going to get weird for a second, okay? And then they can decide if they want to tune back in for the next episode. We're going to explore this right now. But I have said that for so long, ever since I started working in hospice and have kind of watched a lot of processes. It's almost like, so when a baby is born, there's signs leading up, weeks leading up to it. That you go to your OB and they warn you, and they're like, oh, that's Braxton Hicks, that's practice contractions.
Yeah.
Oh, this is going to happen. Oh, this is going to happen. Oh, you're going to have round ligament pain. Like, they warn you about all these things because it's such a celebrated time. But in hospice, unless you have a hospice nurse walking with you through that journey, there's a lot of these things that are going on that are normal parts of the process, but you won't know what they are, because it's not quite the same as labor. There's not like an app on your phone where you can track it that's going to tell you what's going to happen to you this week.
Right.
But also, this is the weird part. Okay, prepare yourself. I have started to almost see it like this. When a baby is born, we get to experience that from the outside. Like, it happens, they experience the contractions, they experience everything leading up to that birth. The baby experiences it from the inside of the womb, right? But when we get to walk with someone to the end of their life, we get to be in the womb as their soul's birth to whatever lies on the other side.
That's true.
And it's a very similar, it's almost like the bookends of life, like they're matching bookends.
They are. There's kind of like a bell curve.
Yes.
Yeah.
And when it's done well,
it's beautiful.
We honor at the beginning, we celebrate at the beginning, and yes, there's grief and there's sadness at the end, but there can also be an honoring and a celebration at the end as well.
Yeah,
which can be really beautiful.
And I just wish that we could talk about it more openly, but it's so taboo in our culture, and it kind of makes me a little sad, honestly, because it can be a really beautiful process. I mean, we all meet our end, but can we meet it well? Really.
That's really good.
Yeah.
I think also there's so many fears around the concept, and maybe that's why we don't talk about it so much, because we almost can feel like what we ignore doesn't exist for us.
Yeah.
But also, where there's a gap where we don't understand something, we can either fill that gap with fear or with curiosity. We can fill it really with that anxiety, or we can fill it with wonder.
Yeah.
Yeah. And I think that hopefully with this podcast, and hopefully for our listeners, we can bring some of that wonder into it too. Yes. Obviously, we want you to have great information, make informed decisions, but also to be able to embrace the wonder of how our bodies know how to come into the world, and also how to let us go to the other side. That's a beautiful thing.
And too, for the family, that's left behind, grieving in and of itself can also be a pretty beautiful process. They're in different parts of the world, in different cultures, historically even, grieving was like a thing that you did. Like, you took days to grieve, and it was like not really a party or celebration, but it was like this, you did it, and I think that here we don't really respect that or give it its rightful time. Like, I think from work you get 3 days off if your very close loved one passes. You know what I mean? That's not nearly enough. And then you don't talk about it afterwards. And so I just think that end of life and grieving well are so
Mhm.
important.
I think so. Absolutely. And letting yourself grieve, letting yourself feel those emotions and go through the process, go through those stages, walk it. I always say, like, walk it almost like a meditation.
Yeah.
Like,
That's good.
as you are doing this to honor the life that was.
Yep.
And sometimes also we have to also honor the life that wasn't. Sometimes there's grief there for what wasn't.
Right.
And
right.
that is a powerful and beautiful thing as well. To let yourself experience that. And release that and work through that.
Yeah, and I mean, whatever you believe about the afterlife or don't, I think is also kind of like an important time to kind of explore that as well.
Yes. And find an understanding that helps you process as well. Even if all you can say is, I hope this.
Yeah.
Hope can still be very beautiful and helpful. And I think even one thing that can be powerful, even though maybe certain conversations didn't happen when your loved one was here, but forgiving them even after they're gone, if that's needed, that can be really, really important. And again, whatever you believe or don't believe, just knowing that for you, if there needs to be that forgiveness and that release that happens as you go through the grieving process, that can be really healing and helpful as well.
Oh yeah, for sure.
Yeah. But these are all things that, if you have hospice, your care team will walk with you through and be able to answer specific questions for you. If in doubt, getting a consultation from a hospice company, even if you find out your loved one doesn't qualify right now, going ahead and having that conversation, asking your questions, meeting a representative, that's always available and is always a good idea. That way you can really make informed decisions when the time does come.
And you can always ask us questions.
That's right. Comment in the comments, please. We want to hear your questions. We want to know what your thoughts are. We want to hear your stories. So as we go along this journey, comment in the comments below. If we get enough questions, we'll probably just do a Q&A session. I would think. Just to take time to answer all the questions and really give you thoughtful responses. So thank you.
Thank you
for being with us today.
It means a lot that you are here with us and that you spread the word, share the word. I think this is an important topic for everyone, truly.
Truly, I think talking about end of life helps us to live our lives better.
Oh yeah.
Ultimately, 100%. No matter where you are in your life journey, talking about the end or being aware of the end or living with awareness of the end can be something that really brings a lot of richness to your life and a lot of gratitude to your life.
For sure.
Because every breath is a gift.
Yeah, 100%. So on that note,
we'll see you next time.
And then they wonder